All right. So look, good evening to everybody, and I'd like to welcome you to this evening's webinar, which is on obesity and its impact on the surgical service. This is a very important topic. Now, before I hand over to Justin, our coordinator of this evening, I'd just like to reflect on last week and just to let you know that at the Charter Day last week, we'd over 2,900 people registering from over 30 countries. And I think we had a very good discussion, robust discussion on diverse topics. So hopefully, if anybody's any ideas for next year, they would be very gratefully received. Anyway, this was an interesting way of doing the Charter Day, but we were able to reach out to a lot of people. Now, this evening, Justin Yegan has very kindly coordinated the service this evening, talking about the service, the surgical service and obesity. And Justin is accompanied by Grace O'Malley, who's a clinical lead in child and adolescent weight management services and is the principal investigator for obesity research and care group at the RCSI, and his colleague, also Professor Helen Henan, who's Professor of Surgery and Consultant Bariatric Surgery at St. Vincent's Hospital. And then Professor Donald Brannon, who's the UCD Professor of Gynecological Oncology and a Consultant Obstetrician and Gynecologist at the Mater Hospital. So Justin himself is a consultant surgeon. I've known Justin for many years at St. Vincent's Hospital, and he's a pathobiliary interest and bariatric surgery. And he helped establish the weight management program at St. Columbkille's and St. Vincent's. And I was reading a little bit about obesity, and I see the WHO recognizes obesity as a chronic disease and obviously risk factor for development of other chronic diseases such as diabetes. And 1 in every 6 Irish adults between 15 and 64 are overweight or obese. 75% of people in the 50+ age group are overweight, and at least 1 in every 5 children at the ages of 3, 5, and 9 are overweight or obese. So those are stark figures. So I'll hand over to you now, Justin, and if you could, Justin, you're chairing it, and so you can introduce your speakers, and I'd be very grateful if you'd start off now.
Okay, thank you, Laura. The plan really is to do, we have 4 presentations, and the plan is to try and keep them to about 10 minutes each.
Yeah.
So that we have plenty of time for questions and discussion. It's late in the evening, and I think the more people can get involved, the better. I'm going to start off with just a short run through some of the areas where obesity and general surgery intersect and overlap.
Yeah.
Hold on, now we get the technology working here. Now, hopefully that's visible to you. So here's a real life scenario that happened last Friday. It was about 5 o'clock, and I got a phone call from one of my colleagues to say, a 59-year-old lady here, she had a sleeve gastrectomy in 2011.
Mm-hmm.
And
just hold on a second, Justin. We just don't have your slides up.
Okay.
Could we have Justin's slides?
Hold on, I will. Let me just try and share again here. Sorry. Now we should get it now.
Yeah, if you put it into slide mode, yeah.
Yeah, sure. Apologies. How's that?
That's perfect. Thank you.
Okay. So this is the scenario I was describing to you. Real life scenario. Last Friday, 5 o'clock, got a phone call to say there was a lady who had a sleeve gastrectomy in 2011, whose current weight was 140 kilos, and she had a tender, obvious abdominal wall hernia. You can see the CT. It's a little grainy because of her size, but she had evidence of small bowel obstruction. And I suppose the question I have for the audience is this a bariatric operation? I mean, she happens to be 140 kilos, but it's an obstructed abdominal wall hernia. So I felt a little gnarly about having to take this on, but I suppose there is a little backstory that you need to be aware of. First of all, I first met her about 10 years before, when she had a BMI of 72. She had an apronectomy that the plastic surgeons didn't really want to get involved in. This lady had an abdominal apron that was actually touching the floor when she stood up, and it was really a life-threatening sort of problem. So I got involved in doing her apronectomy 10 years before, and then subsequently did a sleeve gastrectomy. So I felt a little bit engaged with her. So I did take this on. But my point is, I suppose that not every bariatric patient, or not every overweight patient or morbidly obese patient who has a general surgical problem needs to be going to the bariatric surgical service. This probably is the exception, this kind of scenario. We all know that all procedures are harder in morbidly obese patients, and that there are issues surrounding patient transfer and handling, lots of anesthetic issues, particularly with airway control. Every surgical operation is more difficult in an overweight patient. We all know this. And the complications that occur are definitely compounded by the obesity. But let's face it, it's common. Laura has already quoted some of the incidence figures for obesity in this country. We know that 2.8% of the Irish population are morbidly obese. That's a BMI greater than 40. And we also know that these patients are overrepresented in the hospital population. So you can't avoid it if you're a general surgeon. You've got to be prepared to take on some work in obese patients, and your hospital has to be fitted out to cope with these patients. The little device there on the right, the Oxford Help, is such a simple device, but it should be available in every anesthetic department. It makes endoscopic intubation or endotracheal intubation far easier. I think someone might have their mic on. I'm getting a little echo there. Sometimes patients are referred to the bariatric surgical service, and excuses are given for reasons for not being able to do it in the base hospital. So, you know, longer instruments or longer ports are very rarely, if ever, needed. There is a point, you know, when the patients get to be beyond a BMI of 65, when longer instruments and ports are useful. But below that level, they're not used for any of the routine bariatric operations, and there shouldn't be a barrier to doing a general surgical procedure in an overweight patient. And in this day and age, the weight limit of the operating table is rarely an issue, if ever. Pretty much all modern operating tables have weight limits that are far in excess of anything that most of us will ever see in our day-to-day practice. Let's just focus in on laparoscopic cholecystectomy. For some reason, this is probably the scenario which is, you know, which general surgical patients referred to the bariatric service most commonly. And really, there's just a few simple things that let you do laparoscopic cholecystectomy quite safely in morbidly obese patients. First thing is the camera port. If you place the camera port at the umbilicus, that's going to be an immediate barrier to progress. If you see the diagram here, I've shown the star well above the umbilicus. That's more or less where you have to place the camera if you're going to do lap chole in an obese patient. I use the span between my little finger and thumb to indicate as a measurement from below the rib margin to tell me where I'm going to put the port. If you measure the distance from the xiphisternum to the umbilicus, it's about 20 centimeters in a 70 kilo, 5 foot 10.5 inch male with a normal BMI. I've tried it on myself. So it's about that span. And if you place the port in a bariatric patient, if you use that measurement, it usually gets you into a pretty good position. The problem with the very overweight patients is if you use the umbilicus as a landmark, your camera can end up 60 centimeters below the xiphisternum. And if you think that the length of a laparoscope, a standard laparoscope, is about 31 centimeters, I think, you can see that you're just completely out of touch if you're using the umbilicus as your insertion point. So that simple trick alone converts a lot of cholecystectomy in obese patients into a straightforward procedure. I think it's important to, if you're putting the port in up there, you've got to use a VisiPort or OptiPort, one of those systems that allows you insert the camera under direct insert the port under direct camera control or optical control. The angle that you put the port in is very important. When you've placed the ports, they should be pointing at the gallbladder when you take your hands off them. If you have to apply lateral force to the port to angle it at the gallbladder, you're decreasing your ability to carry out fine movements. That may not matter so much in a thin abdominal wall, but it begins to matter a lot in a very thick abdominal wall. And the other things are just very simple, things we know from regular cholecystectomy, but all the little simple things add up to a big problem if you don't apply them in obese patients. So a 30-degree scope is critical. It's very common to have to put a fifth port in for liver retraction. Same sort of table tilt maneuvers that we use for regular cholecystectomy become very important in this population. And every now and again, it's worth increasing the insufflation pressure to 18 millimeters of mercury, provided the anesthetist is happy that the airway pressure isn't pushed up too much. These balloon ports are great for some situations, but they're terrible for obese patients, so they shouldn't really be used in this scenario. So, you know, laparoscopic cholecystectomy in obese patients, it's the same indications for operation. It certainly does increase operative time. It increases wound infection rates, but it doesn't preclude day case cholecystectomy. And I suppose another question I might have for the audience is there a BMI limit at which patients should be referred to a bariatric center? Just wanted to touch very quickly on another area of intersection between general surgery and obesity. And these are the sort of a couple of bariatric surgical problems that may present to the general surgeon on call. So firstly, as they relate to band problems, the commonest band issue is band slippage, and you can usually see it pretty obviously on the plain X-ray. The yellow line shows the angle at which the band should sit normally. When it's rotated down, as shown in the image, then it tells you that the band has slipped. And of course, it's not the stomach, it's the stomach slipping up through the band rather than the band slipping down. Now, usually removing a slip band is pretty straightforward, and it's done as a day case laparoscopically. And simply you cut the band, you make sure there isn't any residual fibrous scar tissue deep to the band, because that can sometimes cause a persistent restriction, and that's usually pretty straightforward. It is worth checking what band type the patient has. This picture is of a thing called a minimizer band, which is particularly unpleasant to take out because you get tissue ingrowth into the little securing loops. Nobody who designs a gastric band ever assumes that it's going to be taken out. They assume it's always going to be present forever and do its job forever. But of course, more than 50% of these bands are taken out. So that unfortunately is not, the design is not matching the reality of what happens in the real world. Before you take a band out, it's really important to do a gastroscopy to exclude erosion into the stomach. You can see a retroflex view of the upper part of the stomach with the band exposed just below the OG junction. If you remove a band like this laparoscopically by cutting it, you will end up with a hole in the stomach, of course. And the operation to fix that is deeply unpleasant, and it's really a lot more complicated than it needs to be. When the band is eroded like this, the treatment is actually endoscopic. The band can be cut using a device that's passed with the endoscope and pulled into the stomach and then back up through the esophagus. So although this sounds like a more serious situation from the patient's point of view, it's a lot, the recovery is a lot easier actually once it's taken out. The one scenario as a general surgeon that you must be aware of is this situation where you got a laparoscopic band with slippage and bad pain. That's an indication for an urgent endoscopy. Infarction of the proximal stomach is actually pretty uncommon, but it does occur. And as a general surgeon, you need to be aware of this potential complication. And clearly, this is an indication for urgent open operation. And you know, maybe this is a scenario where you should be referring the patient, but I think you need to do the gastroscopy to make the diagnosis before you move the patient on. The other important complication that people doing general surgical calls should be aware of is this problem of internal hernia post gastric bypass. Now, this occurs in about 3 to 5% of patients after a standard gastric bypass. It's almost unique to gastric bypass patients. You don't see it in other patients who have Roux-en-Y loops performed for other indications, probably because the Roux loop that you make in this scenario is very long. It's 150 centimeters long, and that is probably a major contributory factor. The patients will often have abdominal pain, distension, vomiting, all the signs of obstruction, but the clinical signs can be minimal. They may be minimal. It's really important to be aware of this potential diagnosis and to go looking for it, and to have an early threshold for scanning, laparoscopy, and further intervention if necessary. And the problem with it is that it can result in absolutely catastrophic small bowel infarction if the diagnosis is missed. There are a whole bevy of typical CT signs. You can see these whirling distortion, this whirling distortion of the mesentery. That's probably the classic sort of thing. But it's all about clinical suspicion and going looking for it. And if a patient has a history of intermittent episodes of pain, that's an indication for elective laparoscopy to look for these problems. Now, if you remember nothing else, if you remember nothing else in this presentation other than this, if you ever find yourself in the position of doing an operation on somebody who has an internal hernia causing a massive sort of volvulus of the small bowel, it's really difficult to untwist it if you start from the roux loop and work down. You should start from the terminal ileum and work proximally, and that'll tell you the correct direction to derotate the volvulus. So that's my take-home message from this particular presentation. If you remember that, nothing else, remember that. Now, I had a couple of slides about transplant, but I'm going to just skip those because I think I want to obey my own rules and stay within time. So just to finish up, you know, obesity impacts on many aspects of general surgery. I think if you're in a general surgical unit, you've got to be set up to deliver general surgical care to obese patients. And there are a couple of very specific emergency situations that lead to acute presentation that you need to be aware of as a general surgeon. So that's my contribution to the formal presentations. I'm going to move on to introduce Grace O'Malley for the next presentation on adolescent obesity. Let me briefly turn on my camera here. Okay. So Grace trained as a physiotherapist in Trinity, went on to do a master's, subsequently did a Fulbright scholarship to Yale, where she got involved with examining the pathophysiology of type 2 diabetes in the adolescent population. And following on from there, she did a PhD in UCC and came to RCSI, where she's now clinical lead for the Obesity Research and Care Group. And she has a major interest in adolescent obesity, and this I think is going to give us a taste of what's to come for all of us. So I think it's a really important topic. Grace, over to you.
Thank you, Justin, and thanks everybody for the invitation. Are my slides showing?
Yep.
Okay, perfect. So as Justin mentioned, yes, I work in CHI at Temple Street and also in RCSI, and I'm just going to spend the next 10 minutes speaking about adolescent obesity, and I'm having a little bit of a challenge here with my slides, so apologies. Are they moving forward for you guys?
Yes.
Yeah,
that's
perfect.
Fine,
okay, lovely. So I just want to really focus our attention on how different adolescence is to obviously childhood, but also adulthood, and to think about the prevalence of obesity as it stands now and the complications that we see in adolescents with obesity, and also where treatment is at in the literature, but also where we are in Ireland. So for those of you who remember, or let's wind back to when we were adolescents, which the WHO defines as 10 to 24 years, but in pediatrics and adolescent health, we consider more to be 12 to 16 years. This is a really critical phase of our development. We're seeing huge change in physical, cognitive, emotional, social, and economic resources that actually will bring that individual through for the rest of their life. And we know that at this phase, during adolescence, we have particular health determinants that affect health, particularly things like risky behavior, sexual activity, tobacco, alcohol, drug use, those type of things, but also particular adolescent health problems, and in turn, particular health system approaches and actions in order to address those. Also bearing in mind that the adolescents now are our next parents. For those of you interested in adolescence in general, there's a great Lancet commission on adolescent health, but there's three things in that are particularly of importance, I think, to adolescent obesity. The first one is that we know that access to quality secondary education is the best investment for health and well-being long term for adolescents. So if our adolescents are not going to school because of whatever health problem they have, this is a huge issue. We have to address it. And many of our adolescents with obesity are refusing to go to school because of bullying or other issues. So that's something that's a major issue for us in the hospital. Also, one of the other recommendations was tackling preventable and treatable adolescent health problems while they're adolescents, rather than letting them further develop into adulthood. And this is because you get a triple gain on investment when you actually treat adolescent health problems. But obviously that requires investment in adolescent health, and unfortunately in Ireland it's an area really underdeveloped at the moment. So for those of you in adults, you'll be used to the term BMI and using the cutoffs for adults, but in children and adolescents we use growth references and growth curves to classify obesity. So as Pauline mentioned, about 1 in 4 children are overweight or obese in Ireland at the moment, and if we just look at the range of obesity, it's about 8% of adolescents. So that's, when you look at the census between 13 and 18 years, that it's estimated nearly 30,000 adolescents with clinical obesity, and that increases to 12% at age 20. So there's about 7,000 20-year-olds now with estimated to have obesity or a BMI in the obese range. So we use the 98th centile on the BMI growth chart to classify clinical obesity. So anyone working in pediatrics or adolescents, just make sure that when you're doing your weights in clinic or pre-op, that do take a height also and get the BMI calculated and plotted on a growth chart. All that means is that if you had 100 girls, we'd expect 98 of them to be below this 98th centile line. More worryingly is the severe obesity, as Justin mentioned, and this is because the health risks are increasing as obesity progresses. But in Ireland and the UK, we use the 99.6th centile, so we expect 99.6 children to be below that line for BMI, and then WHO uses BMI standardized deviation score of above 3.5. Don't worry about the classifications too much. There's lots of controversy over what cutoffs to use, but basically growth charts, you have to use growth charts. You can't eyeball this, particularly in younger children. And based on COSI data, which is a World Health Organization study running over the last number of years worldwide, but also in Ireland, it's estimated that 2% of children have severe obesity. So a conservative estimate would be 2% in 18-year-olds. And again, thinking of paediatric care in Ireland and the under 16, so 12 to 15 years, about 5,500 adolescents with severe obesity. And at the moment, we're treating about 250 per year in CHI Temple Street. So you'll all be well acquainted with ICD codes, so classifying a disease, and the obesity code is E66. But WHO in 2001 wanted to really move beyond just giving people a disease label and to think about how that disease affects them or whether it actually affects their health. So in health and medicine, we're very good at looking at structures and functions, but we don't particularly pay as much attention to the tasks of adolescence or childhood and how that teenager participates in school, home life, or society. And this is really important. And I know, obviously as a surgeon, you're interested in pre-op, perioperative and post-op care, but really considering how that child, that adult, that teenager, how this surgery that they're having can affect how they participate in life is really, really important. In terms of complications that we know are increased, because fat tissue is fantastic at going everywhere in the body, and that's allowed us to survive, it means that it accumulates in each of the body systems. So we see children and adolescents with an increased risk of psychosocial problems, cardiovascular, endocrine, musculoskeletal, renal, gastrointestinal, and respiratory. So multiple complications, just like in adulthood. But I suppose the key thing to remember is for many of these children and adolescents, their bodies are still developing, so they are really at risk of being able to actually have optimal development. In terms of surgical services, our biggest referrers would be ENT for the children who have sleep apnea, who may not have ever seen anybody till they're 13 or 14 in relation to their weight, but now they're going for a tonsillectomy, and now they're referred. Also, orthopedics. So musculoskeletal risks are increased. So there's a high risk of slipped upper femoral epiphysis, Blount's disease, which is tibia vera, multiple fractures, increased pain, chronic pain, and bony malalignment, particularly genu valgum and excessive genu valgum, which really interferes with movement. But I suppose the key thing to consider if you're an orthopod is that the rehab of these teenagers is quite different to your normal active, typically sized teenagers. So they need more input, and they definitely usually take longer to rehabilitate. So like in adulthood, we use BMI to look at the size of the adolescent, but that doesn't necessarily mean that equates to ill health. So we use a staging system, the pediatric version of the Edmonton staging system. And this allows us to see, well, is this just a body size issue, or is this accumulation of fat affecting the child? And are they having mild, moderate, or severe complications? And based on that, then you're thinking, okay, well, what type of treatment do they need, and where should they be seen in terms of where in the health service? In terms of what are the treatment principles, they're the same as in adults, except that you're obviously dealing with an adolescent at a time when they're developing their own autonomy. So you're engaging the adolescent in treatment and conversation, as well as the parent, and sometimes separately. But essentially, you're using authentic, empathetic, non-stigmatizing communication. Your treatment is going to be family-based, and you're going to be using agreed goal setting. You're using evidence-based and ethical practice, and then you're really using a holistic assessment to try and understand what the strengths of that child and their family are, and how you're going to improve life for them through your treatment. The evidence for treatment in adolescents, in 2015, there was an overview of 6 Cochrane systematic reviews. So in general, treatment can improve anthropometry. It'll improve cardiometabolic health, cardiovascular health, fitness, and quality of life. The cornerstone of treatment is always lifestyle interventions, particularly for children and adolescents and younger adolescents. And you can get small reductions in obesity, but also improvement in other health variables. In the 2015 Cochrane review, there was only one surgical trial included at the time, and there were a few over 17 drug trials, but they were too limited to make inferences about the use and safety, and there were severe or there were adverse events that were serious consideration. But since 2015, we've had a number of studies published as well. Currently, the NICE clinical guideline for treatment of adolescent and childhood obesity indicates that bariatric surgery is an appropriate treatment for adolescents in exceptional circumstances, and if it's undertaken in specialist centres. So that would be paediatric and adolescent centres where we have the pre and post-op care. From the most recent audit of the British registry, or the British and Irish registry on bariatric surgery, about 10% of the adolescents had a surgical complication, but that there were obviously really good improvements in health, not only the body and structures and functions, but also quality of life and depression, which improved, and the improvements peaked at 6 to 12 months in most, but not all patients. So at the moment in Ireland, we have very limited treatment options for children and adolescents, like in adults, in line with the model of care that's for obesity, which is being launched very soon. We are developing Tier 1 primary care treatment with GP, public health nurse, or health and social care professionals. So this is a one-to-one type brief intervention. In Tier 2, we're looking at more multi-component, multidisciplinary interventions with community-based teams. And then our service, our Tier 3 service in Temple Street, has been operational since 2004. That offers outpatient and inpatient intervention for those under 16. And then hopefully as well, we'll be developing a Tier 4 service in CHI. And that'll be a bariatric surgical service for eligible adolescents. In terms of treatment outcomes, so looking back again on the Cochrane reviews, we see a reduction of BMI Z score from lifestyle intervention, so a small but meaningful change of 0.13 units. That's not BMI, that's BMI Z score. Ideally, you want to get 0.25, but from 0.10 onward, you do get some health benefits. In pharmacotherapy, then, you see BMI decreasing by about 1.3 kilo per meter squared. And then for surgery, that again, that was that one study that was eligible for inclusion in the Cochrane review based on 50 patients. It's an Australian study, and that was 10 times greater than pharmacotherapy. The other source of evidence we have now from hospital-based studies is from observational studies in Ireland and the UK. So Matthew Sabin, Bristol, and his team looked at 137 children and adolescents. These were all with severe obesity and saw a decrease of 0.24 BMI STS. We're about to publish on 856 patients from our service, and it's looking overall 0.17 of a reduction. Visit our website if you're interested in the service. And then also Edwards, who saw a reduction of 0.15. I'd point you to the NICE guidelines if you're interested in this area. And the other thing I'd point you to is if you're interested in training in child and adolescent obesity, if you're working in pediatrics or adolescent care in another service, please visit childhoodobesity.ie, because we're looking at training needs assessment at the moment, and also providing an online course which is just about to launch, and it's accredited by RCSI, and also join the Association for the Study of Obesity in Ireland. Thanks so much.
Thank you very much indeed. I think it gives us an insight into the sort of, unfortunately, the generation of adolescents who are going, some of whom will become obese adults, and so there's clearly a need for a job to bridge the sort of adolescent group into the adult group. Perhaps we can talk about that when we get to the end. I'm going to move along with the presentations. Next up is Helen Henan. Helen is a Galway graduate. She did her basic surgical training in Galway and PhD with Michael Cairns in the molecular expression of breast carcinoma and its overlap with obesity. She did bariatric training in Cleveland and in Liverpool and Chester. And Helen is now Professor of Surgery at University College Dublin at St Vincent's Hospital, and she's going to talk about surgical treatment of obesity in Ireland, current and future status. Helen, you might leave your video camera on so people can see you. It's quite nice, I think, if we can see the presenter. That's okay.
Thank you, Justin. Can you see my slides and hear me? Yeah.
Yes.
Okay, good. So for the next 10 minutes, I will explain to you what the surgical treatment of obesity is. So in short, that's bariatric, or often called metabolic surgery, and I'll briefly describe the current bariatric surgery procedures that are commonly performed, but most important, give you an overview of where we are with bariatric surgery in Ireland at the present and where we're going in the coming years. So for anybody who isn't familiar with bariatric surgery procedures, or who thinks it's just gastric banding, then I'll hopefully clarify that indeed bariatric surgery, the most commonly performed operations at present are sleeve gastrectomy and gastric bypass. As Justin nicely alluded to in his presentation, the majority of operations we do related to gastric banding now are remove them for emergency problems or for complications. Largely failure, actually. They're not the most successful operation overall, and it's taken a number of decades to kind of realise that. So there's a redundant procedure now, but there's thousands of people in Ireland who have them in situ, so we have to deal with the legacy of that, which is usually in an emergency setting. As I mentioned, the most commonly performed operations are the sleeve gastrectomy and gastric bypass. The sleeve is probably the most commonly performed operation worldwide at present because of its simplicity, but mainly its efficacy. It's a safe operation that doesn't take a lot of operating time and has a quick recovery as well. These operations are all performed laparoscopically, can be done robotically, but laparoscopy is the most common approach to them. Most centres that perform bariatric surgery now operate according to the principles of an enhanced recovery after surgery programme. Certainly we do. And what the components of this, obviously there's multiple, but we do achieve day of surgery admission and a minimum length of hospital stay, usually 2 days. You could discharge many of these patients a day after surgery if you had good follow-up protocols and good nursing support and clinical support afterwards. So the patients are well enough often after 24 hours to be able to be discharged home. Our typical practice is to keep people 2 days. These are really safe operations. complications. And I suppose that's one of the main messages I want to get across today. The mortality for bariatric surgery is equivalent to that of laparoscopic cholecystectomy. So it's overall less than 1 in 2,000 patients, particularly with the more recent laparoscopic series with hundreds of thousands of patients globally analysed in them. Major complication rates are low as well, in the order of about 1 in 100, and they would include things like leak and bleeding. In terms of who's eligible for surgery, I'll just briefly remind you of eligibility criteria. So currently, these criteria date back to 1991, and they haven't really been updated since. So we still are kind of committed to these sets of criteria that were established by the NIH back in the early 90s. They stipulate that a patient is eligible for surgery. This doesn't mean they want it or are, but they're eligible if BMI is over 40, and that's irrespective of health problems associated with weight. If BMI is over 35 and a patient has at least one obesity complication, which could include diabetes, hypertension, sleep apnea, fatty liver disease, any of the many complications that Grace also showed in her presentation, then a patient is also eligible. It is, however, really important and a nice criteria as well that patients have previously attempted weight loss in supervised programs, and it's been documented that they've been unable to attain a sustained weight loss. And that typically involves using not just diet and lifestyle interventions, but weight loss medications as well. There's only been one update to these criteria over the last 20 years, and that is by the International Diabetes Federation, who, after a number of randomized control trials looking at the effect of bariatric surgery on type 2 diabetes compared to medical treatment, found that bariatric surgery is a really effective treatment for putting type 2 diabetes into remission. So the guidelines do now state that bariatric surgery should be considered for patients with type 2 diabetes and even class 1 obesity, which is a BMI of 30 to 35, who have inadequate glycemic control despite optimal medical management. So this is just one slide to highlight the effects of surgery on obesity complications. Obviously, the most important thing the patients come to our clinics for is seeking weight loss. And the typical weight loss result from the sleeve gastrectomy or the gastric bypass is roughly 25 to 30% of pre-op weight. And that's attained usually around the 12-month mark post-op, but weight loss can continue for up to 2 years. It's unrealistic to expect patients to lose half of their body weight, regardless of if you want to achieve that, you need to do a much more malabsorptive operation like a duodenal switch or a biliopancreatic diversion. But these operations that I've just mentioned, the typical weight loss is about 25 to 30%. The more important benefit, I think, of bariatric surgery is the impact on obesity complications, as are shown here. I'll just highlight some of the more impressive ones that we see routinely, which would be the remission of type 2 diabetes, which is achieved usually overnight after surgery. And this highlights to us that surgery works in ways other than through weight loss. So we now have far better understanding of the weight-independent mechanisms by which bariatric surgery works. It also achieves a 40% reduction in the risk of cardiovascular disease and of cancer, particularly obesity-linked cancers. From a patient's perspective, the most important thing they document post-op is the improvement in their quality of life, which 95% of patients would report. So just to get to the main point, I suppose, is to describe to you where we are with bariatric surgery in Ireland. Well, firstly, again, as you've heard in the earlier talks, we have a huge demand for this service based on the prevalence of obesity at present. There's been one study or data set that has looked at the potential number of patients eligible for bariatric surgery in Ireland. So if we use the criteria that I alluded to earlier and apply them to our adult population, now bear in mind that the only data we have that looks at objectively at BMI in Ireland is the TILDA data set, which includes adults over the age of 50. Then if we look at patients with a BMI over 40 or over 35 with comorbidity, then we've almost 100,000 patients who are currently eligible. And even if we were to really strictly rationalise bariatric surgery and only offer it to patients who have a BMI over 35 and diabetes with diabetic complications, then today we have over 11,000 adults over the age of 50 who'd be eligible. I think this data really underestimates the demand because the average age of patients who present to our clinics is actually in the early 40s with severe obesity. So I think we miss out on a large cohort of patients who'd be eligible and who would want surgery by only looking at older adults. In terms of current service provision, We don't do well at all. There's 2 centres that currently can provide bariatric surgery, ours in Dublin, based at Vincent's and St Columkille's Hospital, and the centre in Galway University Hospital. And together, I suppose until 2017, we were doing less than 100 cases per year between both hospitals, which is not even 0.1% of our current demand. So we weren't doing very well. But things have improved across both sites in recent years, but we're far from where we need to be. If you look at our performance in terms of the number of bariatric procedures per 100,000 adults, we're actually the worst performing country in the Western world in that regard. We perform less than 1 per 100,000, whereas the next lowest would be the UK with 20 per 100,000. So we have a long way to go to get up to speed in terms of our volume. The biggest argument that people would have against us doing more would be that we can't afford to be doing these surgery for people with obesity. And I'd like to just show you some data that says we can't afford not to do this, because obesity complications cost the HSE a fortune. Take, for example, a patient with obesity and type 2 diabetes. That patient, if a patient has gone on insulin for type 2 diabetes, their medications per year cost almost 4,500. That's not including outpatient visits, not including treating complications. It's just daily medications. We've performed a cost effectiveness analysis study and looked at treating 130 patients a year who have diabetes, comparing the cost of surgery with medical treatment for diabetes, and found that at 3 years after bariatric surgery, you've already recouped the cost of surgery. And in fact, you've saved almost 90,000 euros on that 130 patients. If you look out 10 years, given how many patients stay in remission from diabetes, you've saved almost 2.5 million on every 130 patients. So surgery pays for itself time and time again. Looking at our service in Vincent's, I want to just illustrate to you that this service can be developed and delivered on a hub and spoke model. It doesn't necessarily have to be performed in Model 4 hospitals. So we have set up our service using our spoke hospitals in St Michael's Hospital and St Columkille's Hospital. We deliver all of our outpatient work in St Columkille's and then perform surgeries in St Vincent's and in St Michael's, which is a Model 2 hospital. We do carefully select patients for there, particularly the lighter patients. And for us, that's BMIs in the low 50s usually, or high 40s, low 50s, and slightly lower risk patients in terms of obesity complications, but that works well. I'll skip through this really quickly, our data. We've done over 380 cases, I suppose, to date since August 2017, which is when I started. This is with Justin's help. This data is both of ours combined. We have the typical spectrum that any bariatric centre would see in terms of obesity. Our BMI is, our average BMI is probably higher than other obesity or bariatric centres internationally at 52, but that probably reflects the legacy of the really long waiting list for surgery in Ireland, which is about 5 to 6 years at present from the time of referral. But that's because of poor access. We have the typical outcomes. We do slightly more sleeves and gastric bypasses, but still perform up to over 40% of our cases are gastric bypass. You can do revisional procedures. So this includes patients who've had previous bans and can convert them to sleeves or bypasses. And can do simultaneous procedures at the same time. So as Justin said, we often get patients referred with who have severe obesity and symptomatic gallstones, and if we can get them through our programme in time, then we can perform simultaneous cholecystectomy or indeed hernia repairs if they're necessary. Just want to highlight that we haven't had to convert anybody to an open procedure for the primary procedure in 3.5 years, and we've only had 2 ICU transfers. You don't need to have ICU routinely available for these patients. We've had 1 elective admission for a patient who had previous history of multiple episodes of respiratory failure. In fact, he extubated fine, so didn't need it. But we had had arranged that in advance of surgery, and we'd only 1 emergency admission for a patient who developed bronchospasm at extubation and required 4-hour stay in ICU. We don't routinely use HDU either, just for higher risk patients. Our mean length of stay is 2.3 days, and thankfully we've had no mortality to date, and our morbidity, readmission and reoperation rates are in keeping with international standards. So our weight loss, again, is as expected, as is comorbidity resolution. So in terms of developing services in Ireland further, Grace mentioned that we do have a model of care for management of overweight and obesity in Ireland, which was finalised late last year and thankfully was approved at the clinical forum in December by the Chief Clinical Officer. So this is a really major step forward in terms of achieving proper funding for bariatric surgery in Ireland. Following on from this, there has been a draft implementation plan. And what's relevant again to this audience is that the plan recommended 6 bariatric surgery centres in Ireland in the next, I suppose, 5 to 10 years or so, one per regional health group or but the Department of Health are at the minute arguing that we don't need 6, we might need fewer numbers doing higher volumes. But again, that's all to be discussed in the coming weeks and months. But it does seem likely that bariatric surgery is going to get properly funded for the first time in the coming months, which would be very exciting. It is clear that the plan immediately will be to develop existing services, which are those in Vincent's and in Galway. And by 2025, it's envisaged that there will be one other specialised service. The location of that is undecided, and it will be a case of expressions of interest from other hospital groups to see who could deliver that. Obviously in tandem with an MDT to prepare patients appropriately beforehand. And again, it is recommended by the Department of Health that the service would be set up, as is ours, on a hub and spoke model, with surgeries performed in the Model 3 or 4 hospitals and outpatient services in Model 2. The target volume for Ireland is 1,200 cases per year nationally. That would not even bring us in line with European averages, but it would obviously be better than what we're doing at the moment. That would be, if there were 3 centres, 400 cases per year. But teams would be appropriately staffed and funded to deliver that. So we'll finish there and welcome any questions. I'll just summarise by saying that bariatric surgery is safe and clinically effective. It can be done in Model 2 and 3 hospitals as well. It's cost effective, as I've shown you, and in Ireland we obviously have a really high demand but very limited capacity at the moment. It needs programmatic funding to develop this and expand the service nationally to get to our target volume of 1,200 cases per year in the coming 4 years. But this does need appropriately trained surgeons and properly funded centres with skilled MDTs to deliver this. That's really important. Thank you for your attention. I welcome any questions at the end.
Thank you, Helen. That was rapid run through a huge amount of information, but I think, really good overview of where we're at and where we need to get to. You mentioned that obesity is definitely linked to the evolution of a certain number of cancers, and our next speaker is going to really zone in on one of these topics. Donald Brannon is a UCD graduate. He got a very sound training in molecular oncology, doing a PhD in his earlier years, and maintained links with the Conway Institute after doing this. He did his surgical training in gynecological oncology in Ireland, and then did fellowships in gynae oncology in Australia, as well as a fellowship in general and colorectal surgery to augment this. So he's now Professor of Gynecological Oncology in UCD and the Mater, and he's going to talk about obesity and endometrial malignancy. So Donald, if you're there, you might grab the screen.
Donald, do you want me to share your slides?
I think I can share them. Hi, Justin. Okay. Can you guys see me there? Can you see my slides?
We can see your screen. If you want to put on your video, it's nice to be able to see your face while you're talking, actually. I'll get out of the way.
1 second there. My video is on. I'll crack on. Yep. Just so I don't. So thanks for the invite to talk about some of our work that we've been doing on, I suppose, endometrial cancer. This is work that we've been doing in conjunction with Helen and my own group in Systems Biology Ireland in UCD. So really, I suppose we all feel that obesity will become the greatest carcinogen in the Western world, at least over the next 20 to 25 years. And that epidemiological data is becoming stronger and stronger. And this is data from back in 2008, based on BMI rates from around the year 2000, where we saw that for every 5 unit increase in BMI, the risk of developing cancers increased by about 1.5 to 2 times. And there seems to be some degree of difference between the development of cancers between men and women. As you can see here on the right-hand side, the blue graph shows the relative risks associated in the male population compared to the red in the female population. And from a general surgical point of view, I suppose esophageal adenocarcinoma is the key carcinogen-related or cancer-related to obesity. But in gynecological cancer, endometrial cancer is, and whilst adenocarcinoma of the esophagus is, of course, a very aggressive disease. Endometrial cancer, particularly in the obese population, is quite an indolent disease and offers us a very unique opportunity to study how one can design novel interventions. This is work we did in Australia when I was there, where we looked at the Australian National Endometrial Cancer Study, and the epidemiological data there showed very clearly an almost dose-response relationship between BMI and risk of endometrial cancer, as you can see here. But what was really interesting and what piqued our attention was that when we looked at weight cycling, in particular, that whilst patients who gained weight had an increased risk ratio, those who lost weight almost brought their risk back down to what would have been considered a normal rate at an odds ratio of 1. And this was a very important epidemiological observation about the fact that weight loss may actually reduce your risk of developing endometrial cancer. It was kind of backed up at that point by work that came out of Sweden, and Helen didn't really allude to it, but the Scandinavians have been really promoting metabolic surgery for many years, even in what we would consider the non-obese population. And this is a large study that came from Sweden, the Swedish Obese Subject Study, the SOS study, and basically what they looked at was cancer incidence in over 2,000 patients who'd had either no weight loss intervention or metabolic surgery. And what they saw was about a 30% reduction in the incidence of cancer. And this was nearly predominantly seen all in women. And of course, there were far more women in the study than men, as is often the case in a lot of these studies. But they subsequently demonstrated that over a 15-year time period, some maybe kind of helping, backing up what Helen has just spoken about, there was a persistent weight loss of approximately 20%. But there was a major reduction in the incidence of endometrial cancer in particular, and this is probably what was driving the effect that was seen in the entire cohort. And really, that was important epidemiological data that helped us decide about how we would develop our current research program. And this is just a case study. This is an interesting case. This is a 51-year-old who came into my clinic about 4 years ago with a grade 1 endometrial cancer, and she had a BMI above 50. She had extremely poorly controlled type 2 diabetes and had very significant peripheral vascular disease. Had a FEMPOP bypass. She'd lost a couple of toes. She was almost wheelchair bound. And she came in with a paper saying that I needed to do a laparoscopic hysterectomy and pelvic and para-aortic lymph node dissection ASAP. So we had a long conversation, and she was actually turned down by the anaesthetic team for laparoscopic hysterectomy. And I suppose it's important to remember that when we're trying to do pelvic surgery compared to metabolic surgery, we do need deep reverse Trendelenburg position to actually do the operation. And this is an even greater anaesthetic challenge than even things like a lap chole. So following a lot of discussion, I picked up the phone and rang Helen and said that we need to have a look at this lady, and Helen agreed to see her urgently and performed a laparoscopic sleeve gastrectomy, and she reduced her BMI from 56 to 48, and you can see her weight loss on the screen here. And we put a Mirena coil in her uterus as a way of delivering progesterone, which we know can be effective as a conservative way of buying time for endometrial cancer. And we sampled her endometrium at 3 monthly periods. This is based on a trial that we were running in Australia at the time called the FEM study, which is really the first randomized trial looking at weight loss. But the weight loss in the FEM study is through Weight Watchers, and we're only aiming for about a 7% weight loss. So this lady did very well. As Helen alluded to earlier, within a week of her surgery, she was off all anti-diabetic medications. Within a month, she was off most of her anti-hypertensives, and she proceeded to continue to lose weight. And about 6 months later, we performed a laparoscopic hysterectomy, and she actually went home before 8 o'clock the next morning after her laparoscopic hysterectomy. The unfortunate thing here is that this lady actually did develop recurrent disease about 2 years later, and that's something that I'm going to come back to in a few minutes. But ultimately, she was never going to be suitable for primary surgery, and she herself was very thankful for how we have managed her. As a result of this, we went on and did a number of these procedures, and we've done 12 to date. And you can see that these are patients with a high level of comorbidities, and you can see the average BMI here. And what we found is very interesting. So these are patients who all have either complex atypical hyperplasia, which is a precancerous lesion that will generally progress to endometrial cancer, or grade 1 or grade 2 endometrial cancer that is confined to the uterus. And they're either patients who want to retain fertility, and that's an increasing problem worldwide, where we're seeing a lot of younger women, and maybe alluding to our talk about adolescence, where we're seeing a lot of young women present with infertility and endometrial cancer and obesity at present, or women who are deemed not suitable for surgery due to their comorbidities. And what you can see really is that this is the data set, and I'll come back to it in a few minutes, but the average age of the patient was to date is 44, nearly 45 years. 7 are premenopausal, and the average BMI is about 55. And 4 patients have gone on to have laparoscopic hysterectomies after their surgery. But what's been really interesting has been the relationship between the pathological response and weight loss. And this is a waterfall plot, and 3 of the patients have complex atypical hyperplasia. So we're just looking at the 9 patients here who have had endometrial cancer, and you can almost start to see this dose response again, where the more weight, the higher the percentage weight loss was associated with better response. The red mark here is a lady who recurred, and she actually had what we call a microsatellite unstable tumor, similar to microsatellite unstable colorectal cancers, and they're actually known to be more aggressive. And really, as a result of that, we wouldn't offer patients with microsatellite unstable cancer this sort of procedure going forward. And the 2 patients who've had stable disease are the 2 on the right in the grey bars, and they were the lowest. They lost the least amount of weight. But the blue bars all have had a complete pathological response. So interestingly, 6 of the 9 patients with endometrial cancer, when we proceeded to either sample their endometrium or do hysterectomies, had no residual carcinoma left after weight loss above 20%. And this is a very novel finding, as you can gather. With regards to morbidity, the patients have done very well. As Helen alluded to, the length of stay was about 2 days. We've had there's been 1 grade 3 morbidity for the sleeve gastrectomy, which was a post-op bleed requiring transfusion. And 4 patients have gone on to have hysterectomy and have had no morbidities at all. And the weight loss is in keeping with what you would see in other bariatric procedures. I think it's important to understand how morbid hysterectomy can be in these patients. And this is data that we published last year, or well, a couple of years ago now, where we looked at patients who declined enrollment in our FEM study. And what we saw was that there were 167 medical comorbidities noted. 26 patients had laparoscopic hysterectomies. There were 2 conversions, which is 7%, which is much higher than we'd expect. But within 30 days, 12 patients had 30 adverse events, which is much higher than we expected. This is work we've done where we've tried to estimate the probability of severe adverse event after laparoscopic hysterectomy. And you can see it's almost a dose response curve with regards to BMI. So our own group are currently working on this at a molecular level to see what's happening in obesity-related cancers. And what we feel is that this is probably related to the immune response, as well as the kind of classical idea that there's increased circulating estradiol as a result of adipose tissue and aromatase activity. And what you can see really in this slide is that anything that's marked in red are considered non-obesity related cancers, and anything in blue is an obesity associated cancer. And what we're really seeing is that there's much less immune infiltration into cancers associated with obesity. And this is based on large data sets from the Cancer Genome Atlas. So what we've actually found from our own patients is that obesity is associated with what we would call immune cold tumors. And what I'm going to show you here is just very simple immunoscore, which you will be well used to from looking from those of you who work in colorectal cancer. But these are 2 almost identical endometrial cancers. The only difference is the cancer on the left of the screen is a lady with a BMI of 46, and the cancer on the right of the screen is a lady with a BMI of 26.5, normal BMI. And what you can see really is the first up on that we looked at PD-L1 expression, which is a marker of immune activity, and you can see there's very little PD-L1 expression in the patient with BMI of 46. But also, as we move down, we look at CD3 and CD8 cytotoxic T cells. And basically, if you look at the bottom of the screen, there's much more CD8 positive T cells in the lean patient compared to the obese patient. And this is novel data that's just under review at the moment. And when we look at this in a cohort of patients, you see an almost reverse correlation between the number of CD8 positive T cells at the invasive front of the tumor on the top graph here compared to BMI. And also you see a much less reduction in PD-L1, which is what we'd expect. What's interesting, I suppose, is that weight loss appears to heat up the tumor. And this is where it gets very interesting, because if we can demonstrate a mechanism as to how weight loss may change cancer biology, it will make it much easier to implement public health measures going forward. And this is the lady I spoke about earlier who lost his weight went from 177 kilos to 151 kilos. And this is as we sampled her tumor going forward. And you can see at diagnosis, there was very little PD-L1 expression, but by the time we did her hysterectomy, there was extensive PD-L1 expression on the right-hand side. And likewise, we saw a significant increase in the CD3 and CD8 positive T cells as she lost weight. And this is very, I suppose, novel data. We've managed to confirm that in mice, where we fed mice high-fat diets and inoculated them with tumors. And basically what we've shown is that as you make mice more obese, you get less T cell infiltration into the tumors. And also, interestingly, the T cells there's not only less infiltration, but there's actually the T cells are less active, and that's very important. And you can see on the right there that the mice that were fed high-fat diet have less interferon gamma, less granzyme B, and less Ki67, which is a mark of proliferation in the T cells. So one of the things that we really wanted to look at was, can drug-induced weight loss impact endometrial cancer biology? And what we've recently done is an animal study looking at a BD2 ham rat model, which is a spontaneous model of endometrial cancer. And we treated them with the GLP-1 agonist liraglutide for 3 months. And these rats, generally between 50 and 70%, developed cancer by the age of 15 months. And what you can see in this study was that in the standard group of 17 rats, about 50% of them developed cancer, but in the liraglutide treated group, only 20% developed cancer. And we saw about a 20% weight loss in that group as well. And interestingly, all of the cancers developed in the liraglutide group were not what we would associate with the low-grade tumors that we would generally associate with obesity. And this is just some of the data that we work with in our own lab. But really, what's really interesting to us is this is RNA-seq data from the liraglutide-treated rats. So this is a PCA plot. But what you can see over on the left-hand side of the mark is that all the liraglutide-treated animals almost cluster together in the red circles. And what we found, interestingly, is different to what we saw in the humans, and that is that the liraglutide may have an anti-inflammatory response, as I show you on the right. So you can see all the green arrows on the right are pointing downwards. They're pointing away from the black circles on that graph. And that's quite interesting, because it seems that maybe liraglutide may have a separate impact rather than weight loss. And we know that liraglutide has a significant impact as an anti-inflammatory model. So really, as we move towards the clinic, and we need to ask what do patients want, because there's no point in designing all these sort of clinical interventions if we don't know what patients are actually going to think is appropriate. So we did publish on a cohort of 45 women with endometrial cancer, and we asked a couple of interesting questions. One was, is obesity a disease? And 86% felt it was. These were all obese women with endometrial cancer. But only 53% believed that it could cause cancer, even though all of them had an obesity-related cancer. And interestingly, when we asked them about interventions, it was clear that these patients were interested in diet, medication, weight loss surgery, and 85% felt that they would feel that this would be an option they would prefer rather than hysterectomy. And we asked them a final question, which is important as we design things going forward, and that was, if 25% weight loss could treat endometrial cancer without needing hysterectomy, what would you be prepared to consider to achieve this? And half of them would consider diet and medication over surgery. So I think going forward, we need to think about that. So to summarize, as I said, obesity will be the greatest carcinogen in the Western world. Understanding that mechanism is really key, and that's what we spent a lot of time working on in the lab, because if we know anything from the smoking story, it took a long time to prove, I suppose, that smoking was a cause of cancer, and therefore to implement the appropriate public health measures. And you could argue that some of the food companies or the tobacco companies of the 50s are the food companies of the 21st century. Obesity appears to increase immune dysfunction, and that's well described. But our findings regarding weight loss that improves the anti-tumor response are very novel, and these may be very important if we can help preserve fertility and reduce perioperative morbidity. And our data around liraglutide is very interesting because we know liraglutide is a very good weight loss medication, but it may provide us with additional options, particularly in the preventative area where we are trying to treat women with maybe high BMIs who have a significant risk of developing more complex atypical hyperplasia of the endometrium and carcinoma. And I'll just acknowledge the people who work in this and those who fund our research, and I'll hand back to you, Justin.
Donald, fascinating stuff. Absolutely fascinating. It's come such a long way compared to the old days of doing open gastric bypass out in Loughlinstown, believe me. Let's have a few minutes just to take some questions. There's a big audience with some plenty of opinionated people out there, I know. I'm just going to fire one question here from Paul Balfe to you, Donald. Just, you mentioned one of your patients has recurrent disease, and Paul was wondering if that's metastatic. What stage was that at presentation?
Yeah, so that's metastatic disease. She presented with a large lymph node in her groin, of all places, which is rather unusual, but has responded very well to immunotherapy, and is now actually, I suppose, well, she got metastatic disease, but she's had almost a complete response to immunotherapy.
Okay, please put questions into the chat function there if you have any questions. Just another issue that was raised by Dermot. I'm guessing that's Dermot Hare, I think, is it? Talking about complex abdominal wall repair in obese patients, and asking, should we be prioritizing these patients for bariatric procedures to facilitate the abdominal wall repair? Helen, would you like to pitch in on that?
Yeah, I think in an ideal world, if you could do it in a timely fashion, then yes, absolutely. You're at a lower risk of recurrence. You reduce all the surgical risks that Justin mentioned. We can't, there's so many people we need to prioritize, and our waiting list is hundreds, if not thousands, of patients to get into clinic. It's about 6 years at the moment to go through our system. So, if a patient could wait that long, then certainly I think their hernia repair would be both easier and the results better. But at the minute, we have the logistical challenge of our massive waiting list. Justin, I don't know if you'd add to that or agree, but
yeah, sure. I mean, you get into a big discussion about how you prioritize these kinds of treatment. One of the slides I edited out was to do with renal transplantation. These are a group that we do currently fast track because the gains seem so enormous. The only two operations I know of that save money are renal transplantation and bariatric surgery, and if you can combine the two, you can create so much extra funding to do other things that seems like a reasonable thing to do. Now, you can have all kinds of philosophical questions about how you prioritize patients. I think it becomes very difficult. It's a bit like the vaccine prioritization sort of discussion. Any other questions? Laura is asking about semaglutide and its role. So again, Helen, you know more about this than I do now.
Yeah, well, there was a landmark paper published just last week that looked at, so semaglutide, in case anybody doesn't know, is the long-acting GLP-1 analog. So typically used in type 2 diabetes for glycemic control, but it was noticed in that cohort that GLP-1 analogs can lead to weight loss in a significant number of patients. So semaglutide at a higher dose than we typically prescribe it for diabetes can lead to significant weight loss, like up to 20%, almost what we can achieve with surgery in a number of patients who don't have type 2 diabetes. So this randomized trial with over, I think, 6,000 patients published just last week showed that almost everybody got at least 5% weight loss, but about 10 to 15% of patients got 20% weight loss, and about 30% got 10 to 15%. So really, really groundbreaking results for us. The problem is it's not reimbursed. In Ireland. It's really expensive. So it's an injection, a subcut injection once a week. It's a gut hormone, so it's quite a safe drug with a very good side effect profile, but it would work out about $250 to $300 a month. and it would only work for as long as somebody took it. So there's a lot of I suppose downsides. It needs to be reimbursed, I suppose, and if it were prescribed in a level 3 or level 4 centre for obesity management where it was well controlled, I think it should be reimbursed for those people. Yeah. But it will be a game changer for obesity treatment.
Yeah, good. Well, listen, maybe it's late, Justin, at this stage. Listen, that was a fascinating evening, and thank you very much, Justin, for coordinating the evening, and to all the speakers. I mean, it's clear we have to expand our bariatric surgery, whole infrastructure. When you think of, when you done your talk, weight loss changes the biology of tumours, it's so important. And then the money, bit that you showed about the diabetes versus, weight, it's really it's a game changer really to just increase our services as much as we can and support that. I mean, the other thing is, Grace, you've talked about adolescence and everything. I think that we really also need to maybe look after our children. I mean, I think the figure at the moment is the total lifetime cost of childhood obesity in Ireland is 4.6 billion. And that was a figure given a few years ago. So we need to educate, I suppose, our children, and I think your work is excellent. So again, look, thank you all very much, and particularly Justin for coordinating the whole evening. I wish everybody a good night, and I hope your families are well, and I hope that you're well, and everybody remain well. So thank you all, and good night.
Thank you.